probably reserve the questions for last. Okay, so we now live in extraordinary times, historic times even. I'm pretty sure that in the future, when we ourselves are old, for those of us that are kind of young, our grandchildren will probably ask us about, you know, the so-called pandemic that happened in the 2020s. But this is really quite historic. So COVID-19, it's a new virus which we think was formed and spread from Wuhan, China. It's also called the SARS-CoV-2. It belongs to the coronaviruses, which is a family of viruses that cause the common cold. And the symptoms appear 2 to 14 days after exposure. And the most common symptoms are fever, cough, shortness of breath. And the most vulnerable population are the seniors and the immunocompromised. So those that take steroids, those with autoimmune disorders, diabetic, and so on and so forth. And the question is, you know, does COVID-19 affect the central nervous system? So the answer is yes. So for instance, about 1/4 of patients with COVID-19 that were hospitalized had symptoms referable to the central nervous system. So for instance, headaches, dizziness, impaired consciousness, confusion, hallucinations. And then a number of these patients have also been described to have seizures or strokes or brain hemorrhage. And the so-called cytokine storm has been thought of as the main culprit for the widespread damage or the acceleration or the increased frequency of death or incidence of death in this population of patients that are affected. And the same cytokine storm is probably responsible for formation of blood clots that eventually cause strokes in some of these patients. And then the next question is, does COVID-19 affect the peripheral nervous system? So again, there have been reports of patients that developed either neuropathy or myopathy from COVID-19. The good news is that there is no direct viral invasion that has been noted of the motor neurons or peripheral nerves. But nevertheless, since many of these patients make it to the ICU, they're very sick, they stay in the hospital for quite some time, they develop what's called critical illness polyneuropathy. So this is not something unique to COVID-19. This is something we see very commonly in critically ill patients from whatever reason that are hospitalized and have a prolonged stay, especially in the ICU. And then some of these patients develop myopathy, which usually manifests as muscle aches. You measure their enzyme levels for creatine kinase. These levels are elevated. And then there's a question as to whether the virus itself attacks the muscles and causes viral myositis, although I don't think that's been proven beyond reasonable doubt. And then there's been some reports of Guillain-Barré syndrome or GBS. So this is an ascending paralysis. It usually starts at the lower limbs and then slowly rises up. And they eventually, if they develop more severe stages of GBS, may have some paralysis of their respiratory muscles that's requiring them to be intubated. And then the more important question is, are Parkinson's patients more susceptible to COVID-19? And the answer is no. So there is no evidence of increased susceptibility of getting infected with COVID-19 when one is exposed. However, Parkinson's patients are considered high risk nevertheless. So if a Parkinson's patient develops, unfortunately, gets infected with COVID-19, and given that they're elderly, and given that they may have impaired swallowing, they may have difficulty clearing their secretions, their cough reflex may not be very effective. They have some restricted lung disease because their respiratory muscles are weaker to start with. Their muscles in their chest that are needed for respiration are weaker. Then these patients in general are just more high risk for more severe infection. And then there's this recent report in a very reputable journal called Parkinsonism and Related Disorders, which just appeared in May. And these were two Parkinson's patients in France that presented with worsening of their Parkinson's prior to the diagnosis of COVID-19. So the first one was an 83-year-old gentleman who had deep brain stimulation years before, presented with worsening of speech, swallowing, and balance. And then only 5 days later developed fever and cough and pneumonia and was tested for COVID-19 and was positive. In the other case is a 73-year-old woman, again with deep brain stimulation, history of DBS, presented with increased falls and worsening of speech, and only 2 days later presented with confusion, not even a cough, but her chest scan showed pneumonia at that point, and her COVID-19 test was positive. So what these two case reports tell us is that if a Parkinson's patient suddenly has a worsening of their Parkinson's symptoms, or has more imbalance, or has more falls, or has difficulty with their speech, or more difficulty with their speech and swallowing, maybe that patient should be tested at the point for COVID-19. And then some of these early COVID-19 symptoms may actually overlap with Parkinson's symptoms. Like for instance, fatigue is a very common symptom in COVID-19 and Parkinson's. What about loss of sense of smell? Yep, that's very common in both conditions as well, even before the diagnosis is made for either of these two conditions. Muscle aches, weakness, hot flushes. So there really is an overlap in some of these non-motor symptoms and motor symptoms overlap between COVID-19 and Parkinson's. Therefore, the clinicians and caregivers or patients themselves should be aware of this. Now, can the drugs used for COVID-19 cause neurological damage? And I'd like to focus on chloroquine or hydroxychloroquine because there is evidence that this can cause toxic neuromyopathy. Although this is mainly seen in patients with prolonged use, where, for instance, patients with autoimmune disorders like lupus may be prescribed chloroquine or hydroxychloroquine, and it is the chronic use, not the short-term use, that is associated with this toxic neuromyopathy. And then there's some patients with myasthenia gravis symptoms or presentation that may be due to chloroquine, or if they already have myasthenia gravis, a worsening of their weakness. Now, some studies have shown, though, the good news is that some studies have shown that it might actually be useful for Parkinson's. And chloroquine or hydroxychloroquine activates a certain protein called NUR1, which is nuclear receptor-related protein. And this protein is critical for the development and survival of dopamine neurons. And so there's studies many years ago that say that maybe this set of drugs called NUR1 activators may be useful for Parkinson's patients. But again, there's no studies that I know of that have actually formally studied any of these two drugs for Parkinson's. So should Parkinson's patients take any special precautions outside of the usual? And the answer is no. No more than the usual elderly precautions, so avoiding crowds, staying home as much as possible, social distancing, washing your hands for at least 20 seconds, use of alcohol-based hand sanitizers, wearing a mask whenever you go out in public, and avoiding touching your eyes, nose, and mouth with your hands. Now, what about vitamin D deficiency? So they seem to think there is some evidence that those that are vitamin D deficient have a greater risk for major complications from COVID-19. And we know that vitamin D plays a role in your immune system. It also has an anti-inflammatory effect. And vitamin D is rich in certain food items like dairy products, cereals, fatty fish, sun-dried mushrooms. We can also produce it in our own body if you get enough sun exposure. Now, is there evidence that Parkinson's patients are vitamin D deficient and therefore may be at risk for greater complications with COVID-19? And the answer is also yes. So about 55 to 84% of Parkinson's patients are vitamin D deficient. And in fact, vitamin D deficiency is thought to be one of the predisposing factors to Parkinson's. And we also know that vitamin D affects motor and cognitive functions, both in Parkinson's patients and in the normal population. And then the other question that I've been asked by many patients is, does COVID-19 predispose to the development of Parkinson's disease? And the answer is only time will tell. Although for any virus or any infection to cause Parkinson's or Parkinsonism, either in the acute or chronic stage, that particular infectious agent should cause some inflammation in the brain, or the so-called encephalitis. So is there evidence of encephalitis with COVID-19? And the answer is yes. There have been reports of encephalitis with COVID-19. And in fact, a very similar pandemic, and in fact, the last pandemic that occurred before now is the Spanish flu pandemic of 1918, which also involves a flu virus, H1N1 influenza virus. It actually affected even more people, 500 million people. It caused encephalitis lethargica. So many of these patients developed inflammation in the brain. One of the hallmarks is that they got very sleepy or lethargic. It was also called the sleepy disease. And either in the acute stage or in the post-encephalitic chronic stage, they may develop Parkinsonism. And in fact, more than 1 million cases of Parkinsonism were seen with the 1918 flu pandemic, or Spanish flu pandemic. And they also noted that individuals who lived during that era and were born between 1888 and 1924 had a 2 to 3 times greater risk of developing Parkinson's in comparison to those who were born before before 1888 or after 1924. So, for instance, here's a video of a patient with Parkinsonism as a result of the 1918 flu pandemic. And he really presents with classic Parkinson's features: stoopness of posture, hypomimia, tremor, forearm swing, shuffling gait. So patients with post-encephalitic Parkinsonism can present very similarly to Parkinson's disease. And then there's other movement disorders that have been seen with the Spanish flu pandemic, including dystonia, chorea, myoclonus, and even tics. And then lastly, are there any antiviral drugs currently being used for Parkinson's that potentially may have an impact on COVID-19? And the only antiviral drug that we use for Parkinson's nowadays is amantadine. There is a cousin of this called rimantadine, which was developed and marketed primarily in Russia, but it's also available in the US. And amantadine is an antiviral drug that works against influenza A, and it blocks viral replication. Now, amantadine is rarely used nowadays for the flu prevention, though, because many patients have become resistant to it. Many individuals who develop influenza A or other forms of flu have become resistant to it. However, it's still being widely used worldwide for Parkinson's, where it is actually useful for dyskinesias. The main property it has is this anti-dyskinesia effect for more advanced Parkinson's patients. And then there is a group of scientists that believe that, or propose, should I say, that maybe amantadine may block the viperin channel in COVID-19 and may prevent the release of the viral nucleus into the infected host cell. So this is just conjectural at this point. This is just a hypothesis. There's really no evidence yet. Only time will tell whether some of our patients who are on amantadine, whether the frequency, I should say, of COVID-19 affection or severity is less in patients who were exposed to amantadine for many reasons, including Parkinson's, versus those that were not. And then lastly, for our next seminar in August, I think August 21st, I've been asked many times by patients about this news report that came out of stem cells from the skin of one patient that were harvested and and cultured and made to differentiate into dopamine cells, leading to cure. So this is a preview of what we're going to be discussing, hopefully in the next seminar. And then at this point, I'd like to open the floor for questions and answers.
Dr. Evidente, you have about 9 questions in the question box.
Okay, let me take a look at those questions. Hold on. Okay. Is it possible to know the source of the statistics used in this presentation? Yeah, just email me, or should I say, what is the best way, Melissa? Should they contact you?
Yes, they could send me an email at director@mdfa.us, and I could forward it to you.
Okay, perfect. Next question, is the biopsy covered by insurance? Yes, Medicare covers this without questions asked. For commercial payers, we usually get pre-authorization. So far, we've been very successful, even with the commercial payers. Even the VA or TRICARE or TriWest will cover this with the proper pre-authorizations. Next question, do you recommend skin biopsy for family members of Parkinson's? Interesting question. Well, have we done skin biopsies of patients with no motor symptoms but have been referred to my office for REM behavior disorder? The answer is yes. And have we detected alpha-synuclein in those patients? Yes. And have we done DAT scans on those patients, and have we seen abnormal DAT scans? Yes. So we think that these patients are in the pre-motor stage of Parkinson's. So I probably wouldn't do a skin biopsy at this point for just about anyone that has a family member. I would probably wait for at least REM behavior disorder to come out, plus other non-motor symptoms like poor sense of smell, constipation, mood disorders, and so on and so forth to come out. And then if they do have this non-motor symptoms, especially RBD, in the context of a family history, I'll probably say, yep, it's probably worthwhile to do the skin biopsy at that point. Okay, next. How do I get into the phase 3 study to reduce alpha-synuclein? Okay, you just have to find the centers wherever you live, the centers that are participating in these studies. So it's kind of easy to Google this online as to which centers are participating. I know for a fact that they are looking for patients in the earliest stages of Parkinson's at this point. So, and they're looking for patients that so far have not received any treatment for Parkinson's. I won't be surprised though if after the initial studies on untreated early Parkinson's patients that eventually they will branch out to and now study patients with more advanced Parkinson's and those that are receiving treatment. Next question, is REM disturbance or REM behavior disorder with no other Parkinson's symptom a reason for skin biopsy? Yes. As I said, if you have a sleep study proven RBD or REM behavior disorder, you will have a 50% chance of blossoming into a synucleinopathy within the next 10 to 12 years. So the answer is yes. Hi, I just wanted to ask, what are the management on how to relieve the pain associated with muscle spasms in the shoulder? Usually we give muscle relaxants, or if this is Parkinson's related and related to muscle rigidity, then the Parkinson's medication should work as well. What causes or triggers muscle spasms? As I said, the muscles become rigid. And also, Parkinson's patients are more prone to muscle spasms anywhere, and the most common would be leg cramps or back spasms. I also noticed that patients will tend to have involuntary movements of their legs or dyskinesias together with pain from the muscle spasm. Sure, and in fact, dyskinesias can coexist with dystonia or muscle spasms in the same muscles. And some of these patients, some Parkinson's patients will develop painful dyskinesias. Also, one form of this dyskinesia is dystonia, and dystonia can be painful. Is there management to decrease dyskinesias? Yeah, I just mentioned amantadine is the most common. And of course, deep brain stimulation is the most common thing next to amantadine if they don't respond. If they have severe dyskinesias and amantadine doesn't work, I usually recommend deep brain stimulation. PD affects more men than women. You know that there was no relation between PD and COVID-19. However, it is most interesting that more men have suffered from COVID-19 than women. Yeah, I think that's interesting as well. And again, only time will tell as to whether COVID-19 would predispose to develop the Parkinson's down the road, and then how many of these patients that develop in the post-pandemic times, let's say a few years from now, how many of these patients that have de novo development of Parkinson's disease, how many of them actually had COVID-19, how many will be men versus women? That would be interesting data to collect over time. Should people with Parkinson's take vitamin D supplement? Usually we do a vitamin D assay. Believe it or not, even if you're exposed to sun and get lots of sun exposure, it doesn't mean that you're not vitamin D deficient. As I said, the prevalence of vitamin D deficiency in Parkinson's is as high as in the 80s percentile or percent, and therefore one can measure this in the blood. It's a very simple blood test. I also wanted to ask what management or drugs can we take to slow the progression of Parkinson's disease? Well, that's why we're working on it, right? I think the main way based on what I've spoken so far, the main way to slow down Parkinson's or reverse it is to take away the alpha-synuclein. And so we're working on different strategies, which I just alluded to in my slides. Also, during pain experience, during muscle spasm, can massage or hot packs somehow relieve the pain? Yes, absolutely. Next question. What are the criteria to be the phase 3 study for exenatide? Okay, you should not have received any treatment for Parkinson's, and that you should have the early motor symptoms of Parkinson's. Should not have received levodopa, should have not received any of these MAOB inhibitors or dopamine agonists, and they are going to do a DAT scan, a dopamine scan, as part of the study to really confirm that you have abnormalities that suggest that you have early Parkinson's. If you are already diagnosed with Parkinson's disease, should you still get a skin biopsy? Well, what did I say? That the rate of misdiagnosis of Parkinson's, even among experts like myself, is 25 to 50%, depending on what study you look at. So if you have levodopa responsive Parkinson's and the levodopa responsiveness is enduring, so 5 years or more have passed, you still are responsive to it, and more so if you develop levodopa-induced dyskinesias and motor fluctuations, probably there is no reason to do the biopsy at that point. However, during the first 5 years, if there's any question as to whether you have Parkinson's or not, or you're not responding the way you should be or are expected to, or if you don't tolerate the Parkinson's medicines, then I would probably say you probably need a skin biopsy to really confirm whether you have Parkinson's or not.
Awesome. Thank you, Dr. Evidente. Oh, we have one more question.
Okay. I know I had abnormal DAT scan associated with diminished uptake in the left putamen. What is the putamen? Forgot to ask you what are you doing. Okay, remember we talked about the caudate and the putamen. So that is part of the basal ganglia. So the caudate and putamen, or the part of the basal ganglia called the striatum, controls your movement. It modulates your movement. So abnormalities in the basal ganglia are associated with movement disorders like Parkinson's. And in Parkinson's patients, it is the putamen that is hit first. So if you do a DAT scan in early Parkinson's, I showed you the DAT scan films a while ago, the putaminal signal is reduced first, the tails go first, and then eventually the caudate head also gets involved. Is taking vitamin C with zinc recommended for Parkinson's patients to protect and increase immunity against COVID? Well, there's really no good studies that vitamin C and zinc really work to prevent COVID-19. But in general, there seems to be some evidence that increases your immune mechanism. So generically, yes, I would say that vitamin C and zinc may help. We know that zinc helps prevent the common cold. As to whether that combination of vitamin C and zinc, helps COVID-19 is yet to be determined. And as a neurologist, do you think we are nearing to a cure? I think we're coming closer. The fact that we're now focusing on ways to remove this alpha-synuclein from the brain and from the tissues in Parkinson's tells me that we're coming closer to a cure.
Awesome. Thank you, Dr. Evidente.
Okay.
Anybody has any